Thank you, the moderators. I shall be speaking French. It'll make it much easier for me and no doubt for you too. Now, the challenge which I have here is to give you indications on the best time for starting renal dialysis in sepsis. Now, the data which I have here obviously come from analysis of the literature and with the guidelines recently published from the expert conference, the SRLF, SFA, GFRP, and the French-speaking Dialysis Society. Now, if we look at what's recommended by the Surviving Sepsis campaign for all types of shock, but septic shock in particular, there are 4 stages. You have hemodynamic support, ventilatory support, and then you have the adjuvant glycemic control and the renal replacement therapy, which come under adjuvant. Now, the question is to know when you're going to need extra renal therapy. Now, there are 2 major indications as suggested in the past. One is to have a better inflammatory response with a better balance of the pro-anti-inflammatory treatment with a selective treatment of inflammation mediators. But after Dr. Inche's speech, this seems to be a fairly simplistic way, and it's quite likely that this won't work. And the next possibility is to simply make up for the kidney failure and have renal replacement therapy when you have multi-organ failure. What can we say about blood purification when you have inflammation? Now, this is an animal study which now goes back some 20 years. It was done with pigs, and it was given an endotoxic shock, and you can see the heart rate went down, the parameters went down, and if you got the volume back up, you got the heart rate back and the mean arterial pressure compared to the control group. And then a few years later, Sander did a study on humans, and with hemofiltration, there was a possibility to clear the interleukin 6 and TNF-alpha, for example, and there was clearance of these mediators. However, on the right, you can see that there was no variation in the plasma rates, even though there had been clearance. In clinical practice, and this is quite recently, Didier Payen tried to see what effect you could get from standard hemofiltration with about 30 milliliters. This is what we use for kidney failure, and this was combined with the standard treatment of septic shock compared to a control group which did not have hemofiltration, and there was no impact on the standard on the length of use of catecholamines, and there was a difference in the hemofiltration mortality rate, but it was not a significant rate. Then there's high volume hemofiltration so that you can have even greater clearance of these mediators, because they thought the dose was perhaps insufficient. And Jonas Boyau's team did this multi-center study, and they compared high volume hemofiltration with a septic shock, and you've got the rates of 70 versus 35 mils per kilo per hour, and you can see again that the results were negative, and there was no difference on mortality, and that was for some 140 patients. There aren't all that many studies. This is the latest meta-analysis, which was published recently on the randomized prospective studies available on the subject. There are 4, not many patients, 460 patients in all, and overall there is no significant effect of high volume hemofiltration for septic shock. So the authors concluded that there was not sufficient data to recommend this as a routine treatment. So if we go back to the original slide, the effect on the inflammation mediators is not there to provide it. It's not providing evidence for it to be used. So we end up with dialysis, renal replacement therapy to make up for the kidney failure. Now, the key feature to note for sepsis, as you can see on the left here, is that this acute renal failure comes from with multi-organ failure, or multiple organs are involved. And on the right, you can see that acute renal failure by itself will have a number of dysfunctions that go with it and can make the inflammation worse and can contribute to heart failure and other anomalies which will make the shock even worse. So this is acute renal failure, and this can be associated with hemodynamic instability and multi-organ failure. So replacement therapy would be needed. What are the indications and what is the timing, the modalities? You're going to use convection or diffusion, the dose for dialysis, and anticoagulation. Obviously, I have to go through this very quickly because I don't have much time, but I shall attempt to take up the challenge. First, the indication. If I say there's severe hyperkalemia and there's fluid overload, unresponsive to diuretics, severe metabolic acidosis, and symptomatic uremia, I think everybody here would agree that these are the standard indications for renal replacement therapy. If you look at what the intensivists think, this is a survey which was recently published by Mathieu Legrand, and you see that intensivists have a set value of urea, of creatinine, metabolic acidosis, the parameters which you can see on the screen and which I mentioned. But it's also interesting to see that 75% of the cases, oliguria has to be set for the level that you can see there over 6 hours, less than 0.5 mils per kilo per hour. And so if the patient has more than 6 hours of oliguria, then you can start renal replacement therapy. And so this raises the question as to how early it should be done. Here we have a Canadian study, and this is a retrospective study here. And you find the same criteria as the clinical practitioners thought justified renal replacement therapy. You have oliguria, oligonuria. It's set there with the averages which you can see, which justify renal replacement therapy. And then there are the other standard criteria. But what's interesting is to see when you look at the bottom part, when the intensivists on the bottom right thought they'd treated the patient with hyperkalemia in 91% of cases, and for metabolic acidosis in 96% of cases, and for uremia over azotemia in 50% of cases. And that's the case there. And when you look at the standard cutoffs, and you can see them on the left there for potassium, etc., it's less than 10% of situations which are actually concerned by the criteria which the intensivists said would justify renal replacement therapy. So this shows you how difficult it is to set cutoffs and to comply with them. If you then look at the timing, we can see that intensivists usually do it for reasons of oligonuria, and then you have to look at the markers to see if it's going to be early or late renal replacement therapy. And here we have a series of patients, and they looked at the definition of what was early treatment, and they did it with the average time, and the early treatment seemed to have a significant a non-significant effect, says the speaker. But if you look at average creatinine, and you can see that early dialysis seems to be less effective than later dialysis. However, if you look at the difference between creatinine, you've got the same effect. You get an improvement in survival with late dialysis, whereas if you come back up to No, says the speaker. If you look at the time for before treatment, the acute renal failure patient is you need to start early, within less than 2 days. Then it's 2 to 5 days, or more than 5 days. Then you don't get the same results when you look at those different time zones. So the definition of what is early is an important one, and it's a problem at the moment because there's no agreement. What studies are available? We have randomized prospective studies. but not many of them. This is Catherine Bouman with Oudmans van Straten, and this is a randomized prospective trial, and they were 3 groups, so with early dialysis less than 12 hours, late dialysis when they met the usual criteria of complications of acute renal failure, and once they were in dialysis, it was oliguria of less than 3 per liter over 6 hours. That was for acute renal failure. You can see that the early groups usually had renal replacement therapy 6 hours after inclusion, and it was 42 hours for the late group. And when you look at the mortality figures, there's no significance between the 3 groups. Now, 2 comments on this. Now, these are basically post-surgery, post-cardiac surgery patients, and this is a very low mortality level, which restricts the relevance of the study. Now, there are a lot of cohort studies, as you can see in this meta-analysis here. The cohort studies seem to be in favor of early renal replacement therapy, and with all the other limits, it would obviously change from one study to another. And for the others, there was no other significant factors. So it's basically very difficult to work out whether it should be early or not. There are currently 3 studies underway. 2 in France, 1 in Dijon, and 1 in Canada, which is being started, and which may bring us some answers. Another way of looking at things is to see, when you don't start dialysis, when you wait instead of being early, do you actually make the prognosis worse for these patients? And this is what Didier Dreyfus wanted to see in this respective study. These were patients who were included if they had renal failure, and they usually had dialysis only when they had complications, hyperkalemia, and so on, or pulmonary edema and intractable pulmonary edema, and so on. Some had earlier dialysis for reasons which were not necessarily, which couldn't be controlled because it's a retrospective study, and they compared the 2 cohorts, and what they saw was that there was a reduction in mortality with patients that didn't have dialysis compared to those that did have dialysis, even though they met the criteria for renal replacement therapy. Okay, this is a retrospective study, and you can't make it say things it wasn't meant to say, but this is a way of seeing things, and other authors have reported similar effects, and so it's not easy to work out what should be done as to whether it should be early treatment or not. The experts at the conference recently published a study of the analysis of the literature and all the other papers, and they recommend that renal replacement therapy should start as soon as possible when there are life-threatening situations. These are the standard indications which are seen there. And the analysis of the literature cannot help us to define the optimal time for starting when the situation is not life-threatening. There's an important point we need to pay attention to, and that's what Mr. Inche just said to us, and it's the question of fluid overload. And when you've seen these patients who've got they've had dialysis and they have fluid accumulation compared to others, the survival is completely different, and the risk of death when there's fluid overload at the time of dialysis is 2.07 compared to those who didn't have fluid overload. So if you want to carry out the studies to work out whether you should start early renal replacement therapy, the question of managing fluid overload is an important one to note. Another important one is convection or diffusion as the modality. This means, is it going to be intermittent or continuous? There are a few publications here. This is a multi-center study which I was lucky enough to coordinate a few years ago with a number of teams in France, and they compared intermittent hemodialysis and continuous. There were 320 patients, and you can see that there was no difference there at the different days. And then for hemodynamic tolerance, there was no significant difference for hypertensive events whereas intermittent hemodialysis had a few specific treatments, and this has been found in other meta-analyses and on mobility in hospital. We've got a very recent meta-analysis which was published by Bellomo and Sean Bagshaw, and it was on recovery of renal function. If there's no difference in mortality, then some authors thought there might be a difference in recovering renal function, and they thought there might be more hypertension with intermittent hemodialysis and perhaps more ongoing renal failure. And when you look at all these observational studies, you can see that there is a significant difference in favor of continuous methods, and all of these methods seem to show that there's less dependence on dialysis when you have hemofiltration rather than intermittent hemodialysis. And there's just a couple comment about the heterogeneity. There was substantial heterogeneity between these studies, which makes you wonder how they can interpret the results. But when you look at the same study with the randomized prospective studies, there's no heterogeneity in the studies, and there's a negative result. But when you combine it all, you still get a positive result. But I will leave it up to your wisdom to judge the relevance of these studies. So the experts concluded that intermittent and continuous renal replacement therapy can be used. It just depends on what's available in the department where you're working and the experience you have with it. Regardless of the method, use the one you're expert in using and which your team can use efficiently. Otherwise, you're likely to make things worse rather than better. The second recommendation is the choice between diffusive and convection. It doesn't make any difference there, and that applies to both intermittent and continuous renal replacement treatment. If we then look at the Surviving Sepsis campaign, you've got the same guidelines. You've got the same for intermittent and continuous for patients with severe sepsis and acute renal failure 2B. Then there's the question of the dose for dialysis. Here we have some recent studies with large numbers. There are a number of publications that were excellent quality that seem to highlight a high dose around 35 milliliters per kilo per hour. That's for continuous and intermittent with daily hemodialysis. And here you have the study by Pittsburgh and Politsky, and they've questioned this. They had randomized patients. They were put 20 to 35 for intensive strategy, and for stable patients it was intermittent on a daily basis compared to every 2 days. And here you can see the results of the study. There's no significant difference in mortality between the two groups. So if you take the non-intensive strategy, there was a KT over V which was 3.9 a week, and for continuous it was 22 mils per kilo per hour, and urea prior to dialysis was around 24 millimolars before each new session of dialysis. And then the next study is a defined group, and it showed in septic group there was no difference compared to the overall cohort of patient. Now we have the renal study, and again there's no significant difference. It compared 2 doses of dialysis for hemofiltration, and it's continuous. So 33 compared to 22, and there was no significant difference. You end up with the same dose in the previous study with 22 mils per kilo per hour, and for septic patients there was no difference compared to the other subgroups. So here we have a meta-analysis. There are a number of them available. I'll just show you this one, and it shows you there's a trend, but this is because of previous studies, but the difference is not significant. So the expert recommendation for intermittent hemodialysis, the minimal delivered dose should probably be 3 sessions a week with a minimum of 4 hours and a flow over 200 mils per minute. or dialysis flow of 500 ml per minute, or if you use a KT over V 3.9 per week, or a pre-dialysis urea value of 20 to 25 millimoles per liter. So you can then work out the frequency on that, and the dose to be delivered has to be tailored to suit the patient's needs. For continuous therapy, the minimal delivered dose should be between 20 to 25 mL per kilo per hour, no matter whether it's filtration or diffusion. And for septic patients, the dose should not be increased just because the patient is septic. The last point is anticoagulation. One of the problems with the continuous methods, and this is what we saw in the two studies I've just mentioned, when you look at the dose which should have been delivered, the authors should have given 40 mL per kilo per hour for the high intensity, but they could only give 33, and instead of giving 25, they could only get 22 mL, so this is low. And the authors say clearly that this is because of problems of repeated clotting, and that caused the problem, and so there was a lot of downtime, which reduced the dialysis session time. You can see that on the right. And this gives you a variation in the urea levels when you have all these interruptions. So, and in the ATN trial, in the continuous arm, the authors wanted to do it 24 hours a day, but they only did 21 hours, and again there were interruptions. And this is what you usually find. So coagulation is a problem. Citrate is promising. It's meant to find a solution. Here you can see citrate playing a role in coagulation. It's involved in all stages. There shouldn't be a problem if you have citrate, and here you can see the effect here. You've got standard heparin compared to citrate with the electronic microscope images. Monchi showed a couple of years ago that when you got the right heparin or citrate, you had a better filter life, and also it was better for the patients, and this was shown with this meta-analysis. It was a significant increase in filter life, and there was a significant reduction in bleeding episodes. And to conclude, the expert recommendations for continuous renal replacement therapy with risk of bleeding, citrate anticoagulation should probably be the first choice rather than not having it. And when doing continuous therapy, citrate should be considered the first choice. And when citrate